Okay, we'll go ahead and get started. Once again, I wanted to welcome everyone to the second or third Ocumetics Accommodative Lens webinar. My name is Dean Burns, and I will be taking all of us through the session this afternoon. By way of disclosures, here's the disclaimer. The presentation represents my views only. I will make a couple comments about stock and the evaluation of our stock. I personally believe it's undervalued, and we'll talk a little bit about that as we go through the information in the presentation. By way of an overview, I'd like to try to cover maybe 3 or 4 things. We'll spend some time talking a little bit about what the problem is in the eye care space with accommodation and certainly cataract surgery. We'll talk through what the different advantages of solutions are. We have now entered into what I call the FDA journal funnel, which really starts with biocompatibility, but shortly thereafter, we take a pretty interesting nosedive into a journey for first in human. We have 12 steps that I'll go through with you guys so that you know exactly where we are in the process and what we're trying to do. And then we'll talk a little bit about the technology. Once I wrap that up, I'll leave more than enough time for us to have a really good, robust Q&A session. And with the Q&A, we'll talk a little bit about technology. We'll talk a little bit about the clinical stuff, and then we'll wrap up with finance and investment. So if you have any questions in those 3 areas, we'll make sure that we try to address those as we go through today's information. For those of you who I have not had the pleasure of meeting, I thought it would be appropriate for me to kind of share with you who I am and what I'm about. And I'm trying to capture this information in really 3 data points. So first of all, my name is Dean Burns, and I have had well over a 40-year career in the medical surgical device area. So I have a lot of experience when it comes to that. I also have experience in the pharmaceutical sector, but not quite as much as I do with medical surgery. I worked for an organization before coming over to Ocumetics, which was called Alcon Vision. They are the largest eye care company in the world. I spent almost 28 years of my career with them, and I retired in 2020 from them. And when I retired, my last assignment was a senior director role in cataract, where I was responsible for about $750 million worth of top line business, 65% gross margin on that business, and a 3 to 5% compounded growth rate with that. So I've had a very, very, very large portfolio. And through my career, my accomplishments is I've achieved 15 FDA approvals. A person in my space probably gets 1 or 2 FDA approvals. I stayed around long enough and did some pretty unique things in my career where I have 15 under my belt, 15 product launches in 5 different eye care categories. So that's cataract, refractive, vitreoretinal, and pharmaceutical, and then 16 national and international sales and marketing awards. So I've got a pretty good, robust background, which makes me uniquely qualified to do what I'm doing to lead this team through the FDA process and certainly into commercialization with the Ocumetics lens. So the question you should have on your mind is, okay, well, why are you guys conducting this webinar? Well, it's really straightforward. We want to introduce ourselves or our organization to a new community of potential investors. We want to update those of you that have been following us over the years down this journey to FDA approval. And we want to ask for your partnership. And that is on the retail side as well as private placement side. As we complete our first in human studies and certainly go into the multi-center clinical trials with the Ocumetics lens. So that's really why we have positioned ourselves to do the webinar. So what's the issue? Well, the issue is as we age, and I'm in that aging category, so I'm going to say we age, we develop two conditions, and you almost can't separate either one from each other. The first one is by the time we reach the ripe age of 45, we enter into a category of presbyopia. What presbyopia just means is that you've lost the ability to see in the distance as well as seeing up near. Your distance vision is certainly much better than your near vision, but you have to really work at it. You need aid to do that. So that's where readers or bifocals and trifocals come into play. It helps to bring that vision, the close-up vision in particular, more clear. As you age through presbyopia, you actually enter into an area called cataract disease or dysfunctional lens disease. What that is not only do you have presbyopia, but you have a lens, and I'll show you a schematic of that has gotten cloudy, inflexible, and it doesn't function like it used to with your vision. If cataracts are left untreated, a patient will go blind, and it is one of the most sought after treatments to cure blindness from a cataract disease state. So we can cure it, and there are a lot of different technologies, which I'll talk a little bit about to cure that, but it is curable. So when you have a cataract, if you look at this image here, the flower, which is a good example of normal vision. It's got a lot of contrast. The colors are really beautiful. They stand out really well. You can see 3D depth within that image. As you go through your cataract journey, that same image starts to become very difficult to see. It's not that you don't know it's a flower, you just don't know the clarity of that image or that particular picture. And as you go through the pathway, if you don't correct for it, you will go eventually blind. So cataract surgery is a necessary pathway that we all will go down as we age. Well, let's talk about what happens when you're 45 years of age. I mentioned early on this whole notion of loss of accommodation, which means that you can see in the distance and near, and your mind just automatically makes that work. You don't even think about looking up and looking in the distance versus looking down and looking at something near. So the non-accommodative state, and I'm going to use my pointer here, and I hope everyone can see my pointer. This schematic is a cross-sectional image of what's in your eye. I get a lot of questions about why I had LASIK. LASIK, if you can see my pointer, affects the top part of the eye, which is called the cornea. So it's this little area here extended all the way up. When you lose accommodation, it's not that your LASIK has wore off, it's that this tissue here called the interocular lens, the natural crystalline lens, starts to go bad. So on one side, we call it the non-accommodative state. If you look at this lens from top to bottom, it's actually slimmer. The reason it's slimmer is these attachments in this muscle here pull on that lens equally to thin it out so you can see in the distance. When you need to, and when you look in the distance, you can look into infinity. Well, when you need to look close up, these attachments in this muscle actually relaxes and the lens gets fatter, which allows you to see close up. And you don't think about it because the brain and the eye have such a connection that it figures out what it needs to do when it needs to do it. Well, part of the challenge is that whole system gets compromised as we get older. And we have tried as an industry to come up with different ways in which to make the eye work a certain way. And we tried to do it with different kinds of lenses. So on the left side, we have a lens that basically is designed to change the optical property of what you're seeing by just using the lens itself and changing the optics of the lens. Well, that works, but you have a lot of visual disturbances. On the right-hand side, this is a very first accommodative lens. It was called the crystalline lens, and it was designed to work where your eye pushed these little things here, they call them haptics, together. So it pushes them towards the end, and this lens vaults up. And because of that vaulting, you would be able to see near, intermediate, and near and in the distance. Well, that system didn't work really well because not all muscles and attachments work the same. So everyone has been in this unbelievable pursuit of the Holy Grail, which is a true accommodative lens. Well, Ocumetics, in my opinion, has hit a home run. Now, I mentioned in my opening salvo that I was retired from Alcon. I came out of retirement to work on this lens project. When I saw what it was capable of doing, I said, I have to be a part of it. So what is this lens design? Well, it's a optical system that has three different components. So it has an interior optical element, a posterior optical element, which is this green part, and in between there, it has air. The air is what is used to actually move that lens up and down so that you can see far, intermediate, and in a near configuration. So in the schematic that I originally showed you with the natural crystalline lens, during cataract surgery, we would go in and replace that natural crystalline lens that's basically diseased tissue and put the Ocumetics lens in its place. And here is a graphical drawing of what that looks like. So the previous slide I showed you, it had three components. Here is the anterior optic. Here is the posterior optic, and in between the optics is air. So if we want to look in distance, we have to make sure that we can push these lens elements together so that you can see in the distance. So that gives us our distance vision. By the same token, if we want to look close up, we move those two optical elements far away from each other, and that actually gives us our close-up vision or intermediate to close-up vision. The way we do that with the Ocumetics lens, and this is a animation of it, is we allow the muscle to push it down and allow it to release up. And the air that's in between there is what's actually controlling all of that. Now, when I mention air, that's really important because there are other competitors that instead of using air, they've decided to use a different substrate, like silicone oil in their lens. And I'll show you who those competitors are. We chose not to go down that pathway because we know the dangers of silicone oil. And we learned all of that in the plastics area, where manufacturers got away from doing silicone breast implants because the seams would burst, the silicone oil would escape, and patients would be harmed, and they would have to be replaced with saline implants. So we know what the body does when it is invaded basically with silicone oil, and we've chosen not to go down that particular path and just use air. So what is the advantage of our technology for doing that? Well, first of all, it's a one-piece system. It's full of air. So the system is very efficient. It works really well. We move the lens up and down as the animation showed versus sliding the two optics across each other. It's designed to deliver 3.5 diopters of accommodation. And so what that really translates into, I'll give you a real world example, is when you are 45, 50, 55, 60 years of age, you go to the local grocery store or big box store and you pick out a pair of readers. Most of the time you start with 1 diopter, then you go 1.5, you'll go 2, 2.5, 3, etc. We did the same thing with the accommodative lens, except we're going to give you all 3 diopters right up front. So 3.25 diopters right up front, and your eye will actually use however much it needs. So it's a lens that's designed to deliver on the clinical side 3.25 diopters. On the bench, we were able to do it all the way to 14 diopters. So this lens has a lot of breadth and depth associated with it. The accommodative and non-accommodative or disaccommodative state to change from one to the other is very, very fast. And we feel at Ocumetics that that is a safety issue. The example I'll give you is if you're driving down the road and you're looking in the distance and you need to look at something either on your phone or on your dash, and you want that change to occur very quickly. And then when you resume looking in the distance, you want that distance change to occur really quick. So we've designed a lens that changes very quickly, and we're trying to mitigate against any kind of safety issues that might occur from that. The final thing is silicone oil. And I mentioned silicone oil because it is a potential toxic material in the eye. When we use it for retina surgery, we almost always remove it. I can't think of a situation where we would leave silicone oil in the back of the eye. We use it as a tamponade to put the retina back in place. But other than that, we try to clean that whole area out and remove the oil as quickly as we can. All right. So in the pathway for first in human, we had to clear a huge major hurdle, which is called biocompatibility. And I think you've heard or seen at least our press releases that we fared very favorable in our biocompatibility study. So this is a actual surgical footage of the bunny studies that we did. So on the left-hand side is the actual surgery. The right-hand side is what the lens looked like in a dilated eye. Now, I'm not going to show the video because I don't know the temperament of the people that are on the call, if they can stand to look at surgical videos or not. But what I will say is that we fared very favorable compared to a control IOL that's been used heavily in the marketplace for over 10 or 15 years. And we did extremely well. So we were really happy that we were able to pass what we call the safety hurdle. And that's for the material and that's for the design. It did extremely well. So that takes us to the journey to first in human, and I call it the journey to first in human study, because as you can see on the chart or on the screen, there are so many things that we absolutely have to do, and we can't even skip around because these things are serialized. In other words, you have to do one behind the other. So you'll notice on the screen a color difference. Opportunities 1, 2, and 3. So those are steps 1, 2, and 3. We are right there finishing those steps up, or we have already completed those steps. So we just released a new press release saying that we have completed the lens injector system for the lens. And so that's option number 3. So that's done. That's a huge major milestone for first in human, because we need a good delivery system to go into the first in human study. Lenses 1 and 2, steps 1 and 2. 1 is our design freeze. Anytime you go into a study, particularly one that has the regulatory burden that an FDA study would have, you have to stop designing your technology and freeze that design. Well, we have a couple more measurements left to do, and we will be freezing not only one design, but we will freeze a second design so that we have two different designs that we can look at as we go into our first in human and the multi-center clinical trial. And we have started to manufacture those lenses, which was the earlier press release that we released. So we're pretty pumped about being able to do a manufacturing run with clinically optical clear lenses, which is really cool. Sandwiched in between that is we have some regulatory paperwork that we have to submit to the Dominican of Republic and the ministerial authorities there, giving us permission to actually do studies within their jurisdiction. So there's quite a few things here that's on this list, but I'm going to break it down into a smaller bite-sized list that we can look at. So once we submit our paperwork, which is step 2, we have to give the Dominican of Republic up to basically 90 to 120 days to review our application, look at our protocol, and then render us an approval. In between that, we also have to give them the ability to ask us any questions that they may have. So they may come back and say, hey, explain something about your technology. We don't quite understand it. Or they may say, hey, in your protocol, you said you're going to do this with the patient. Can you do something else? So we have to be very flexible and very nimble to answer any questions that may come out of that particular process, with the hope that we get our FDA approval. Once we get the FDA approval, we spring into action with, we have to go conduct, we call it a site visit, but it's really a pre-site visit in terms of, do you have all the supplies that we need to do surgery? Are you ready in terms of the staff to manage the patients that will be coming in? Do you have all of the diagnostic pieces of equipment that we're going to need to evaluate the patient's vision? So we'll do a pre-site clinical evaluation with the site, and then we will follow that up with an on-site inspection. Once we do that, we will deliver all the supplies to the location. Keep in mind, we're going from the US or Canada into a foreign country, so we'll have to make sure that the customs paperwork, including carnets, are done properly. We have begun work on designing the surgical procedure protocol, as well as the surgeon training. The good thing about this technology is the surgeon doesn't really have to change his surgical technique or invest in additional surgeon training. They just need to be able to follow up and evaluate the patient's vision post-operatively. And so that's really where the big surgeon training comes from. We'll do the recruiting so that we have the right type of patient for this technology. We'll do the surgery, and then we have an obligation to track these patients for over 6 months. The endpoints that we will be looking at is, how well do they see 7 days after the surgery? So we call that the 1-week visit. Then we will have another endpoint with how well they see 1 month after surgery, 3 months after surgery, 6 months after surgery. And when we get to that 6-month parameter, that's when we will offer up to the FDA our clinical report, which will then be used along with another document called a IDE, which stands for Investigational Device Exemption Application, that will go to the FDA asking for permission to now do that particular surgical procedure inside the US. And so it's a 3-phase study. You'll hear it discussed that way. And we're hoping that we get that approval so that we can start doing that the middle of next year. All right. So why should investors get involved? Well, First of all, it is a huge market with a lot of patients. There are 138 million patients just inside the US that are 45 years of age or older. When you look globally, this area is a $4.6 billion market. And so that's just unbelievable when you think about it. And that's what we were looking at in 2022. It's forecasted to grow well over 5-6 percentage points on an annual basis. And then the final thing is, I don't ever recall a technology where everyone is a potential candidate. So the lens that's on the finger of this particular image is the relative size of what we're talking about with the Ocumetics lens. It's really, really tiny and really, really small, but yet and still it packs a big punch, and it does a lot for the patients. And we will see that when we do our clinical first in human study, what the performance characteristics are and how much accommodative amplitude patients get with this technology. So we're really excited about it. And once again, it's I'll have to say, and here again, it's just my opinion, but the stock value for what this technology is capable of doing, the stock value is it's just underrated. This is a really fantastic technology with the capability of doing more. For those of you who are interested in just numbers in general, we do have just a working model where we can look at different market points that actually drive our decisions. So here's an example of looking at the cataract only group, so 65 years of age patients. The IOL category, as I mentioned, is well over a almost $5 billion area with a huge growth rate attached to it. If you just look at the premium sector, which is the area that Ocumetics would play in, that's a $1.2 billion area. We think that we will get a 40+ share of that market. And if we do a 40+ share of that market, that's relatively a $500 million worth of potential revenue on one product, which is super nice and exciting. If we expand that group to include all the way down to 45 and 65, and we don't change any of the parameters except the premium category gets a little bit bigger, we'll still stay at 40%, then the revenue opportunity is basically $750 million. And here again, we're talking $750 million on one product. And my numbers are really conservative because of how many potential people will be in the market. If you look at the history of what we've been able to do and some of the projections that we're looking at from a budgeting perspective, we just finished up in 2024, less than a month ago, a $4 million raise. And that raise was for some pre-manufacturing, which we made an announcement on, and to go into our first in human. So 24, 23, and 22, we've really done a very good job of raising money to get us to this point. What's left to do? Well, you can see right there, it's basically $34 million to get to the finish line, broken down into 3 activity areas. And we'll be looking to do some of this stuff and make some announcements later on this year. Right now, I can't even tell you when we would do a private placement and what that private placement amount would look like, but we still have a ways to go, and we will be looking at doing some fundraising for the next round of activities. We can skip over that, but this slide, but we do have our clinical regulatory schedule. It's a dynamic schedule. It's moving very fast, but you can see some of the activities that we plan to do, and those dates do fluctuate based on where we are and the things that we're working on. I get the question all the time about competition. So in the accommodative IOL area, there's really 14 companies that participate around the world in this area, but there are only 6 of us that are at the top of the heap and are really pretty much at the same point in time, whether we are entering into first in human or we've done first in human and we're exiting out. We're all kind of in the same area. And if you know anything about horse races, you know that as soon as the bell goes and they open up the gate, everyone goes to the rail. So there's nobody really jockeying for position because they haven't even gone into the first turn. And so we all believe that there's 6 companies that are right there at the rail together. Ocumetics is one of them, but the reason I've got it separated here is there are 5 companies at the top of the heap that all use silicone oil. And the main reason is because they're sliding their lenses across each other and they need some type of lubricant to do that. Well, Ocumetics is the only non-silicone oil technology, and we haven't really promoted that, but we will start promoting the significance of that from a design perspective. We can't promote clinical perspectives because we're just entering into the early phases of clinical, but from a design perspective, we will certainly do a better job with communicating that out, that we are the only non-silicone oil technology in the heap. So here's the group that is up against the rail. Like I said, we are anchored in this group with a non-silicone oil-based technology. What about IP? I get questions on IP all the time. And we just did a huge analysis on our patents. And we have 49 global patents for this technology. So our IP is really, really, really strong. The areas on this slide that are in a darker blue color are the regions where we have patents. The areas that are circled are areas that we are looking at for early potential commercialization once we get through first in human. And when we do early potential commercialization, that is typically referred to as a CE mark or an ISO approval in those countries with those regulatory authorities. And that allows you to sell your product in that particular market even before the FDA approval. So we're looking at all the opportunities where we can actually sell our product. But from an IP pure perspective, we have 49 patents, global patents around the world, and we are pretty buttoned up with this technology. All right, so what are the investment opportunities with Ocumetics? Well, first of all, when we announce, if we announce, you could join us for our next round of investment opportunities, which will be our next round of funding. So that's one investment option. The second one is you can buy Ocumetics shares on the open exchange. So we are listed on the Frankfurt Exchange and also the TSX Venture. So you can buy off of those 2 exchanges the Ocumetics stock. And if you have stock, you can hold those current shares as we go through our clinical journey, because here again, I will reiterate, I believe the stock is undervalued, and we'll see the true value of this technology once we get in and out of our first in human studies. Now, with that said, Dayton, I'm going to open things up so that we can have time to talk, recognizing that we have a hard stop probably at 7:15 local time, my time.
Excellent. Yeah, I guess I probably should introduce myself. I'm Dayton Marks. I'm a director in the company, and I'll just be handling the Q&A side and passing that off to Dean. So we do have one question, but actually, so we have a couple of other ones as well, and I'll bring those up shortly. But the first question that we have was from Raj, and it said, why are we using air as opposed to saline?
So the reason we're without divulging too much, we've looked at both. We actually have two designs, one using air and one using saline. The reason we used air is you can compress it a lot easier than you can compress water. So when you are altitude, you've got to have a lot of pressure because that lens goes up and down this way. You got to have a lot of pressure exerted, and we use millinewtons to measure it, but you have to have a lot of pressure to push those two lenses together. Water is a little harder to compress than air is. So we chose to go from a design perspective with air for that reason and that reason only. Could we use water? Yeah, but we have to really look at the mechanism of action and make sure that we can allow those muscles to compress that lens up in that down position. Because when it relaxes, it will automatically go to its relaxed position.
Excellent. Okay, we got another question here from Robert. It states, you mentioned, and I believe this is 3.25 diopters up to 14 diopters. Does this mean the default lens is capable of 1 to 14 diopters, or does it mean that the default lens is 1 to 3.25 diopters, but an upgraded lens is capable of up to 14?
Yeah, so the current lens design is able to go up to 3.25 diopters, and that's the only lens that we will take into the clinical environment because the eye won't like 14. It doesn't, that's way too much accommodation, and you wouldn't see well, and your eye wouldn't like that. So we can go from 1 to 3.25.
Another question here. This one's from Robert. Is there any possible dangers of the air leaking into the fluid over time?
So you can never say no for sure. If our seals were to break, yeah, you could, in theory, lose the air that's in there. We've designed it so that that wouldn't happen. In my schematic that I showed a really big dimpled area to the outer edges of the lens. When it compresses, the air actually goes into, we call that the air pocket. It goes into the air pocket, and there are two of them, one at each basic end of the lens. And so when the lens comes down, the air goes that way. When the lens goes back up, the air comes back in. So we've designed it so that we wouldn't have a potential of a deflated IOL. But if it did deflate, it would be a do no harm deflation. Patient would still be able to see well. They would just have a lens that was deflated, and in the accommodative area, we would have to go fix that for them.
We've got a question here from Jeremy, and it states, most ophthalmologists are unaware of Ocumetics, much less have detailed info. How can we, as potential consumers, assess the lens's suitability for our eyes at this point in time?
Yeah, so when you go down the FDA journey or the FDA pathway, if a individual wants to assess the quality of the lens, they would have to actually be a part of a trial, either a multi-center trial or first in human trial. That's the only way that you could actually assess the performance characteristics of the lens at that point in time. The only other time that you would have is after FDA approval, and your doctor and yourself would have to work out whether or not you would be a suitable candidate to have that lens implanted into your eyes.
We've got another question here from Raj. Is there any risk of air embolization?
Ask the question again.
I think it's with real. Is there any risk of air embolization, or I guess air leaking? And I think you'd already answered that to some extent, but if you wanted to go a little bit further into that.
Well, without pictorially showing, there's a ridge around the optics that the muscle sits on top of. And sitting on top of the muscle, excuse me, sitting on top of the lens, it pushes those seals together. So the chance of that is slim to none. But I wouldn't be telling the truth if I didn't say, is that possible? Yeah, anything is possible. But we have tried to really mitigate against air loss because that's truly what helps this lens work the way it does.
Excellent. We got another one here from, or actually, this is from Cecil. Do you have a good idea or what the price of the lenses will look like after it's released?
Can't talk about price. That's a no-no. What I would say about price, though, is if you look at the gold standard that is being used today, so there are a number of companies that actually have a refractive lens that's used for multifocality. So they call it a multifocal lens. There's pricing out right now, and there's two prices. There's a company price to the clinic, and then there's a surgical price from the clinic to the consumers. If you just look at that pricing, that would be a good indication of where most of the companies, if not all, are going to go. We're going to end up.
I'm going to jump ahead to this one because I think this is a great one. This one's from Wolfram. Is it air or an inert gas like nitrogen? Also, how does it react to changes in altitude or depth if you're a diver?
Yep. Oh, that's a great question. I love this one. So first of all, it's not an inert gas, it is air. And the way it reacts is we change the volume of air in the lens so that when you go up in an airplane and you go to altitude, so let's just say you're 30,000 feet flying above the earth, you still have the ability to allow that lens to work properly and to get the benefits from accommodation. The same holds true when you go into the ocean. So if you are a diver, you'll have the same thing. The thing that we here in the US had to mitigate against is we have a city that's a mile high, which is called Denver. So we actually had to design a lens that could be worn in Denver, let alone on an airplane or maybe even deep sea diving. So we've got a version of the lens that can take care of that.
All right, here's another question. This one's from Derek. How many human beings or how many humans are anticipated for the first trial, and what success rate is required for it to be considered successful?
Okay, so I'll talk about first in human first, and then we'll go to the multi-center clinical trial. In the first in human phase, you do up to 10 or 15 what we call subjects. And typically what we do is we do one eye with the targeted technology. And in this case, it would be one eye Ocumetics, and then one eye as a safety lens that has been used in the marketplace. So it's already FDA approved, which is the lens that we will benchmark against. So 10 to 15 subjects would be in the first in human trials. When you get to the multi-center clinical trials, because we have to do statistical analysis, the numbers are even greater. So at a minimum, the FDA will say you need to do 300 to 350 subjects in that trial, and that it's a contralateral eye study. So one eye would be Ocumetics, the other eye would be whatever the control lens is. up to about 350. And in some cases, you may even have to go to 425. So it really depends on what the FDA wants us to do when we actually enter into the multi-center clinical trial. When you put those two numbers together, it's going to be something south of 500 subjects that will have the lens in their eye when we actually get FDA approval.
So this one's from Cecil. I actually gonna jump ahead to this one. Is it still possible to be part of a trial as of right now? Because I get this question quite a bit too.
Yeah, so the short answer is, yeah, anything's possible. What the trial development looks like is the only way you can be a part of a trial is if that physician in your local area is a investigator within the trial. So let's just say Canada, and let's just say Toronto. If we had a surgeon in Toronto that was part of the trial and some of our viewing audience was in Toronto, then they could actually contact that site and say, hey, I'd like to be a part of the trial. Typically what happens is the site will actually promote that we are a part of an FDA study and we're seeking individuals who would be interested in being a part of the trial. Well, as soon as you hear that, you should jump on it, make the phone call and say, hey, I'm interested in doing that.
All right, we got a question here from Ibram. Hello, can the lens provide good quality vision for people with high myopia?
Yes, so myopia or hyperopia, once we take out the diseased tissue, the cataract, we actually correct for myopia or hyperopia. And the way we do that is through the calculations that we use to come up with the lens quality that will be put in your eye. So the short answer is yes, we can correct for hyperopia or myopia, and we do that through our calculations. In addition to that, we give you the accommodative amplitude that we showed earlier, which is about 3.25 diopters of accommodation.
So we got another one here from Tom. I was under the impression that an IOL intraocular lens could not be removed or replaced. Is that correct?
Ask that question again. I think it's kind of a weird question. Ask that question again.
Maybe I'll reword it like this. Can an intraocular lens, so if somebody has a current lens in their eye, can that be replaced with a different lens or I would assume the Ocumetics IOL when it's in market?
Yeah, so that's a lens exchange procedure. In theory, it can be done. Doctors don't like to do it because they set the patient up for other morbidity type issues that are hard to control. So if that lens has been in the eye, let's just say 2-3 years, it's really difficult to remove it because the tissue around that IOL scars down onto the optic itself. And you would have to blunt dissect that tissue off of that optic before you could actually remove it. And the doctors don't like to do that. It's long, it's tedious, it's really hard. It's not an easy procedure. If it had been in there less than a year, absolutely, because the scarring has not occurred. But that's something the patient would have to discuss with their doctor.
We have a question here from Garth. Will you make different sizes or does one size fit all for people?
Well, we will make, from a geometric perspective, a lens that fits into the lens capsule bag. So it's kind of a uniform size, but we will have different diopters of powers within that geometry. So the geometry of the lens should be one size fits all, and we'll come up with what that is as we go through our trials. but we will be able to come up with different optical powers within that lens.
So Nathan asked, will there be an option for elective cataract replacement? If, for instance, the patient has a family history of cataracts, if so, what criteria will be factored into determining eligibility?
Yeah, so that's called a clear lens exchange if you are under 45 years of age or maybe even 65 years of age. It just depends on what your doctor in your local area uses as exclusion or exclusion criteria. But you can elect to have your crystalline lens removed. You can turn that into a elective kind of surgery, just like LASIK, but you have to really talk it through with your doctor and make sure that they are comfortable with doing that surgery for you. The lens will fit in whether it's a cataract uh, uh, issue or whether it's just a refractive issue. The lens will fit into the eye. It's just whatever your doctor wants to do.
Nathan followed up with how long until Ocumetics, well, our lens is available in Canada?
So the short answer to that is I'll give you the FDA journey and the parameters that we're using to get through our studies. So the first in human studies is going to take about 6 months because we have to report out 1 week, as I mentioned earlier, 1 week, 1 month, 3 months, 6 months. So we have to report that out and give that clinical report to the FDA. Once we get through first in human and we get approval to do the multi-center clinical trial, that pathway is usually a 3-year pathway. And it's a well-defined pathway that comes from the FDA. We don't get a chance to really weigh into it. So we could do all the patients really fast in terms of the surgery, but we still have to take the patients through the FDA pathway. So if you add those two together, you're probably looking at about 4 or 5 years from now.
There was a question from somebody. The stock is also available on the U.S. stock market, and the answer to that is yes, it is. And the symbol is OTCFF. Yes, that is correct. Just if you do purchase on that exchange, I would recommend if you're using a discount brokerage, you use a limit order to purchase shares as opposed to a market order. In fact, no matter what the market is, you should always use a limit order as opposed to a market order. There's another question. How does external air pressure affect the lens when you are, for example, high in the mountains or under pressure when you are diving? I think we've kind of already touched on that. If you wanted to go over that one more time.
Yeah, so we've designed the lens to work at altitude or to work if you are doing some extreme sports like deep sea diving. And it works just as well.
There's one here from Julie. I'm nearsighted and have astigmatism and presbyopia. Can the lens correct for these issues?
Absolutely. It was designed to do that. So yes, it can.
There's one here from Mike. My son has nanophthalmic eyes or small eyes. Wears a contact lens, suffered from glaucoma. In one eye, is the lens something that could be an option for him in particular in the future?
Yeah, so I think Dayton, did you say he has glaucoma or keratoconus?
It's stated glaucoma in this question in one eye. So
Yeah. That's really a clinical discussion you'll need to have with your attending physician. First of all, with kids, we don't put interocular lenses in children unless we absolutely have to do. And the reason for that is their eye is still growing. So we may not have a lens that actually would fit into that small orbit until that patient has gotten to a certain size. That's issue number one. Issue number two is as they grow, their vision will change. And so that child would be subjected to multiple surgeries. And so we tend to try to stay away from putting intraocular lenses in children until they are at least 18 years of age and their eye has stopped growing. And that way we can put something in that's just going to be there for quite some time and give them stable vision.
So we have another question from Mark. Maybe I'll take this one. In terms of return on investment over time, would purchasing shares of Ocumetics be better than taking part in a future private placement or vice versa? And I mean, it depends on the size of the investment that you're going to make, of course. For private placements, it's typically for generally larger investors or those that are accredited or have the capability to participate. I'll just go out on a limb and say if you're doing under 10,000, then that's definitely probably just buy in the open market. The private placements will often have warrants or other additional securities attached to them, so they tend to be a little bit more something that investors like, but it depends is the answer. There's one from Melissa here. Can somebody who has a posterior vitreous detachment, or I guess even maybe a retinal detachment in the past, be a candidate for the lens?
I would probably say no.
So here's one. You said versions of the lens. Does this mean that there will be more than one version of the lens being brought to market? What would the difference be?
No, there'll be one version of the lens brought to market, but like a good innovation design company, we'll take multiple iterations into a clinical laboratory type setting and see which one of those versions actually performs the best. And that is the one that we will absolutely take into the multi-center clinical trial. And that is the one that we will actually have commercially available when we get FDA approval. But no, there won't be multiple lenses approved through this process. There's only going to be one lens that's going to be approved through the process. We just want to make sure that we go into it with knowing what the best features and performance characteristics of the lens will be.
So we got one from Fabio. You exposed two different situations for potential patient profiles, but have you included the range from 45 to 65 or specifically at these two ages? I would just, yeah, I guess maybe we should morph that question into what age brackets are the target for Ocumetics or potential candidates. And then the other follow-up was, when do you think it'll make it to Italy?
Yeah, so I'll take the last part of the question first. We're not sure of a date. We do know that when we go to Europe, we're going to go in the 8 major markets within Europe. And Italy is one of the major 8 markets. Where in Italy, we don't know. In terms of the first part of the question, we use a demographic of 45, 65 and older, just as a point of reference to find out where a person's eye condition might land. So you could be a 65-year-old person and have 20/20 vision, and you would not need to have this type of lens. Why? Because your crystalline lens is functioning and doing what it was supposed to do. It hasn't gotten cloudy, it hasn't gotten stiff. Your accommodation is still pretty good, maybe not as good as it was when you were 20, but you still have functional vision. Or you could be a 50-year-old with a brunescent, which is brown, cataract, and you can't see past your nose. But the range that we always use is 45 years of age is where your lens starts to not function well for distance and near. And by the time you're 65, you have early signs of a cataract. So those are just endpoints to tell us kind of where that patient is in terms of that disease progression. It's not an inclusion or exclusion criteria. It's just where you are.
There's one from Michiel. Is there a prescription that's really high, for example, like let's say negative 800, at which the point the lens would not be recommended?
Well, I don't know what negative 800 is. We tend to use the Snell and acuity charts to talk about vision. So 2020, 2010, 2015.5, 2040. So I don't know what negative 800 relates to. But we will have lenses that can correct for those types of ocular situations.
There's a another question here from Raj. So lens accommodation is independent of the status and functionality of ciliary muscles.
No. So that whole process is called biokinetics. And that's where the muscle system, which is a muscle and attachments, those attachments are called ciliary bodies, and that lens capsule and the lens that's inside, all of that working in harmony gives you biokinetics. When any part of that doesn't work or cease to work the way it's supposed to, so the lens gets cloudy, it gets really stiff, the biokinetics of the eyes have now changed, and we need to have an intervention process or mitigation process to allow that patient to see better and have a better quality of life. So all of that stuff is linked together, and we don't really separate it apart. We just try to make sure the system is as strong and is as good as it potentially can be, so that patient gets the best possible performance out of that lens that they can get.
Glenn asked, are there any particular eye conditions that would disqualify you from getting the lens?
Sure. Glaucoma is one, any kind of retinal disease issue. If it's a disease-based process, could be disqualifying. Keratoconus could be disqualifying. So it just really depends on the condition of your eyes and what type of disease you might be looking at. If you have glaucoma as an example and it's out of control, so your pressures are really high, you would not be a candidate for any kind of what we call premium IOL. You wouldn't see well, and you would be frustrated and you would complain. When I say you, I'm talking the patient would not see well. They'd be frustrated and they would complain.
There was a question here from Patrick, just to kind of, if you can discuss the timing of the human trials and maybe a bit of a discussion of when it would be commercially available in different areas.
Yeah, so I've already done the commercially available. It's really after we get through the multi-center clinical trial with the FDA. That's really a 4.5, 5-year pathway that we have to look at. In terms of areas of availability, we've done what's called a total addressable market calculation, and we've looked at where we could potentially release this lens. A lot of it really depends on the regulatory or notifying bodies within those particular countries and how hard or how easy it is to actually get a lens through the regulatory process. So it's really hard to say, hey, it's only going to take 6 months. We don't know, because an accommodative lens is something that the FDA and all the notifying bodies have never seen before. So they're going to scrutinize it a little bit different and possibly even more. So we don't know the exact hardship on the process. We do know that this technology won't be available for patients from a commercial perspective until we get through the FDA process. So that's about 4 years, 4 to 5 years from where we are today.
There's one from Bob here that says, will there be updates during the trial to keep us current with the progress?
Yeah, we decided, I'm going to say at the end of last year, that we need to update the investment community and those that follow us through the newsletter. We need to update you guys on a regular basis. So if you have not subscribed to the Ocumetics newsletter, I would encourage you to do so, because we're going to use that as a vehicle to really update the community at large. You can get to it via the Ocumetics website, and that's www.ocumetics.com. Go into the investor section, and you'll see where you can subscribe to the newsletter. That's going to be the biggest vehicle, other than PRs, to really update everyone. If you want to get an update and you want to just do it at your leisure, you can always come to the website and look at what's new, and you can find out what's going on with Ocumetics.
There was a question from Nathan, and the question was, have you seen much interest from other sectors like the military or NASA?
We actually have not gone into those targeted areas. Typically what will happen, because I've done a lot of work with the military, typically what will happen is the military, and it doesn't matter what branch, will wait until they have something that is FDA approved, because they do not want to subject their service men and women to an unapproved product. And they want to make sure that that product has been well tested before they actually give it to the men and women in the service. NASA is a different animal in itself, because those are military individuals that have changed careers and they're moving into a different area of being an astronaut. So they could have been flight pilots, instructors, combat individuals at bases around the country that have changed careers or changed things within their careers, and now they want to be astronauts. And NASA wants to make sure that whatever those individuals need, they get, but it's something that's approved and it's well documented that it works.
So we had another one from Wolfram. Does the lens affect your field of view?
I'm gonna say yes, only for this reason. When you talk about your field of view, we typically can see, a little bit past 180 degrees. So that's your peripheral vision coming all the way around to your central vision. When we put an IOL in the eye, we're trying to make sure that your central vision is the absolute best quality that it can be. We also want to make sure that when you put that lens in the eye, we don't take away from any of the peripheral vision that you already have. So if you've got good peripheral vision and you get this IOL, you'll have good peripheral and good center. If you've got poor peripheral vision and you get this lens, you'll have good central, but you'll still have the issues that you had going into surgery with your peripheral vision.
There's another question here. How easy would it be to exchange the lens in the event of a post-operative refractive surprise? I'm assuming that would be some sort of a error in the surgery. Are there any concerns about any concerns, especially if there's been a length of time since the surgery? I think is what they're asking.
Yeah, so we call that an adverse event. If there's a postoperative surprise, we'll see that in the first 7 to 10 days. If it's not a big one, doctors will actually have the patient hold for 1 month or maybe 3 months to let the eyes settle down before they will do anything. As long as it's less than a year, it's easy to do an exchange. So it's easy to get in, take it out, and put the right optical power in the eye. If it's more than that, then you've got a whole different set of issues that you have to mitigate around. And doctors don't like doing that. So the short answer is, yeah, we can do refractive exchanges on lenses. They do it all the time. They take them out and put new lenses in. We can do that. But when you wait years, it makes it really, really difficult to even do the surgery itself.
All right, we've got one from Ibram here again. With the Ocumetics lens, can we perform RLE surgery or
Yeah.
clear lens surgery in case of high myopia and presbyopia in the age bracket of, about 45?
Yep, absolutely. That's a good targeted area. And for those on the call, if you don't know what the RLE is, that's a refractive lens exchange. And so that's usually an elective procedure to take out the crystalline lens and put a IOL in its place. So Dayton, I'll take a couple more because we have to stop at about 7:15 my time.
Yeah, well, we've only got really 2 questions left. The first one was from Cecil and Hyundai. They asked, so Dr. Webb had stated that it was of his belief in one of his previous videos that the lens could boost the vision to 3 times that of 2020, or I'm not sure the exact quote, but I guess it's just a follow up on that particular statement. I think it's way back in 2015.
Yeah, so in 2015, I was still at Alcon. And so I'm not really familiar with Dr. Webb's quote. What I would say is that this technology has the ability to improve vision. I don't know if it's a 2x, 3x, 5x. I don't know what that amount is, but I will say the technology does have the ability to allow you to see better, and your quality of vision will be better as a result of the types of optics that we're using to actually design and build this lens. So the amount of what that is in reference to what Dr. Webb had stated, I'm not really sure what that is, but I know the lens has the potential of helping patients to see better.
I think that there was one other question. I can quickly answer that one just privately, but I think that's pretty well it.
Okay. Well, listen, everyone, I thoroughly enjoyed you guys getting on and sharing your questions with us. We're pretty excited, as you can tell by the excitement in my voice, with this technology and what it's capable of doing. Ocumetics, just as a point of reference, is almost a 19-year-old company. 15 to 16 of those years has just been in research and development. And it's only been the last 2.5 to 3 years where we have gone from being a research organization to truly being a development organization, to now have technologies that we can take and put in a human. So we are just elated with what we're doing and how we're doing it, and the partnership that we have with the medical community as well as the investment community so far, who's invested in our technology. And so we just want to invite you to be a part of the excitement. invite you to be a part of the investment rage. I mentioned earlier, and I'll continue to say it and almost sound like a broken record. The stock is undervalued based on what this lens is capable of doing. And so we're all really pretty pumped with what the capabilities are, and the next 6 months are going to be truly exciting for us, being able to take this lens from the bench and put it into a human patient, and having some amazing things happen in those patients' lives. So kudos to Dr. Webb, who came up with this idea years and years and years and years ago, and he's put together a really good team of individuals that can carry this vision across the goal line. So we're excited about it. We want you to be excited about it. If there's anything or any other questions that come up that did not get addressed on the call, feel free to reach out to us on our website, and we'll make sure that we actually get some answers to you guys. Okay, Dayton, with that, we'll close it down.
Yeah, absolutely. Thank you so much, everybody. And we're going to post this as well, right?
Yes.
Yeah, perfect. All right, excellent. Thank you, everybody.
All right. Take care. Bye-bye now.